So as we move on to our third and final session this morning, just before lunch, I'm very excited to introduce the two next presenters who are going to be a tag team to really address what has come up and certainly is a critical question, and that is it time for routine screening? And so to address this question, our thought was that we could bring together representation both from ACOG, and here we have Dr. Emily Miller, who has joined us and will really sort of wear that hat for us today to really share with us where ACOG stands with this question. So just a little bit of background about Dr. Miller. She's an assistant professor. She's an obstetrician and maternal fetal medicine specialist coming from Northwestern University, and she is currently in the NICHD Women's Reproductive Health Research Career Development Program, and is really recognized as an up-and-coming leader in the field with her work both in trying to prevent preterm birth and in her interest in identifying models that can better support prenatal screening for pregnant women. And to co-lead our initiatives, we have our own Dr. Lee Beers, who I just made contact with, who is a pediatrician and is actually our up-and-coming president-elect for the American Academy of Pediatrics. She's an associate professor and really has been spearheading a number of initiatives, not just within our local DC chapter, but certainly nationally, to really help push forth initiatives as they relate to advocacy. She is the founding director, in fact, of the DC Mental Health Access in Pediatrics, and she's also the co-director of ESIN, our Early Childhood Innovation Network. And so collectively, I'm thrilled to have both Emily and Lee share with us both some of their personal work, but alongside supporting the current ACOG and American Academy of Pediatrics for the question, is it time for routine screening? So welcome.
Thank you so very much for the introduction. Really excited to get to talk to you guys, and just excited to work in this kind of synergy. So like was said before, our talk is entitled, Is It Time for Universal Screening? And I have no relevant disclosures except that's not what we're going to talk about. So I think after the past day and a half, we've all listened to the prevalence of perinatal depression. We've listened to the adverse impact on moms. We've listened to it as a leading contributor to maternal mortality, to exacerbated disparities. We've heard compelling data on the impact of antenatal and postpartum depression on fetal and infant development. And so, I don't know, raise of hand, anybody after this think we shouldn't screen? Like, okay, good, that could have gone the other way. Right, so I think we're there, and it's not time. It's been time for a long time now. The question is, how do we get there? And so both of us are going to talk about that question, is how do we move the needle? Like, where are we now and where do we need to go? So what I'm going to do is set the framework of how we're doing on the obstetric end of things in terms of the perinatal depression care cascade, what are our current outcomes, and then go through some evidence-based approaches to optimize screening. And then I'll just turn it over to Dr. Beers, who's going to talk about the pediatric side of things and how our pediatrician colleagues can help us reach this goal. So I'll begin with a question, just to see where you guys think we are, how good you think obstetricians are. What percentage of women with perinatal depression across the United States are going to achieve remission of our symptoms? Because that's ultimately what our goal is, right? To identify disease and cure it. So raise of hands, who thinks it's 3 to 5% of women that are going to get to remission? Okay, a few cynics. Who thinks 18 to 20%? Okay, a few more, 38 to 40%. Okay, a few more, 53 to 55%. Okay, a couple optimists, that's good. Okay, I'm not going to tell you the answer now, but I promise I'll tell you later. So here's the depression care cascade, and I'm a health services researcher, and so kind of dissect out each component of what needs to happen to get us from the goal on the left, which is maternal depression, to our ultimate goal of remission. So how do we step by step get across these processes? And step one is obviously screening, right? We can't move the needle forward if we're not identifying the problems to begin with. It's clear that ACOG, the AAP, the Society of Maternal Fetal Medicine, the USPSTF, for a while now have recommended in their guidelines that we universally screen both during pregnancy and postpartum for perinatal depression. But in my opinion, these are guidelines, and in my opinion, guidelines without any implementation strategy around them are really merely good intentions. And so how do we pivot this from really well-intentioned documents, from really well-intentioned organizations, into what we want to achieve? So these are a group of researchers from Kaiser, Drs. Flanagan and Avalos, that tried to do just this. So they recognized across the Kaiser system in California, they just weren't screening. And the recommendations had changed, and they said, gosh, we really got to do this. And so this is a huge health system. Over the 7 years, they studied about 100,000 women, 500 obstetricians, 100 midwives. That's a lot of cats to herd. And they wanted to look at, okay, what can we do within our health system to get the OBs and midwives to screen? There's a list of the 6 things they did, and I list them really to just emphasize. They put a lot of resources into trying to get this to happen, right? They identified a site lead. They formed a task force, right? You know it is serious if there is a task force. They developed collaborations. They incorporated into workflow, like what works with that system, and really spent a lot of time and energy educating the staff. And what did they find? Well, this is what they presented in their abstract, right? Pre-implementation, they weren't screening. And they poured in all these resources, and after implementation, after doing all of those 6 steps with a lot of rigor, 98% of women got a screen at some point during pregnancy or postpartum. Now, you just heard some uplifting talks and a lot of language around, you know, we want to point to positivity. I'm a glass half empty kind of person, and the therapist in the room could probably bill for this 15 minutes. But this is my interpretation of their results, because what their goal was, and these are really excellent researchers, they did an incredible job, but their goal was to screen at 3 time points. Their goal was to screen early pregnancy, right, to identify antecedent depression, 3rd trimester, to identify incident depression during pregnancy, and then again postpartum. That's their goal. Pre-implementation, obviously they weren't doing it. Rollout, they got better, but even when it was fully implemented, even after investing all of these resources, less than half of the time did they achieve their goal. And I don't think we should stop there. I think we, as an audience, need to be better advocates. Like, I think if we said, hey, 49% of the time we'll get to where we want to get, like, that would be terrible. So I think we have a lot of room to do, and my perspective on this is trying to force a system into force something to happen within our existing health system, and I think we need to reimagine what the health system is and the breadth of the health system to be able to really get these numbers up. Okay, really quickly, I know we're talking about screening, but obviously screening does nothing if we don't implement treatment other than kind of waste a lot of paper. So this is the same study, the same Kaiser study. They wanted to look at what percentage of women achieved some kind of treatment. The OB or the midwife said, hey, you know, here's some kind of intervention in the face of a positive screen. And I don't want you to get too bogged down in kind of what the different colors are. Those are just kind of what aspect of treatment was recommended. But the concept here is that they engaged in this universal screening. They improved screening rates. Actually, rates of treatment went down. And some of that makes some sense, right? You're universally screening. You're picking up a little bit less severe morbidity, whereas if you're not universally screening, you're picking up people that, like, look a little rough in your office. So there's probably more severe. But nevertheless, I think it's really important to recognize that without some, again, implementation science around treatment, we're going to have less than half of women identified to have symptoms achieve any type of intervention. And then finally, I want to introduce the concept of stepped care, which many in the audience are probably quite familiar with, but it's fairly novel for obstetricians. Is this concept that we need to, if we're engaging in pharmacotherapy, potentially dose increase as pregnancy progresses. And I'm going to focus a little bit on pharmacotherapy. I think the same would probably hold true for psychotherapy, but I want to stay in my lane a little bit. So adequate trial of treatment, these are really compelling data that my wonderful mentors and colleagues, Dr. Wisner, Dr. Clark, Dr. Stitt, work in, and they look at on the left hand, on the y-axis is the level to dose ratio, kind of concentration in the bloodstream, and then on the x-axis is as gestation progresses and then postpartum. And all I want you to get from this is levels change. And then if our goal is a therapeutic concentration of a medication, we're going to have to increase the dose to achieve that same concentration. And so what that suggests is our general obstetric model of like, I screened, I'm giving 25 milligrams of sertraline, I'm rocking it, like that's probably not good enough. And these are the same data just presented in clinical format. This is specific to sertraline, and these are Dr. Wisner's data of women that were given sertraline, what percentage achieved a remission. And again, these are just so compelling to say if it's less than 100 milligrams, only 4% of women achieved remission of their depressive symptoms, right? It's not good enough to stop there. We have to engage in stepped care. And so these are meta-analytic data that have been published looking at, and the gray bar is antenatal depression, and then the black bar is postpartum depression. And what you can see is each step of that care cascade as it progresses, we have dramatic drop-offs. And back to that initial question I asked you guys, what we see is 3 to 5% of women with perinatal depression across the United States are achieving remission. That's really terrible. And what, that's complicated. We can certainly talk offline about that. The question was what time frame. But I want to kind of highlight where the biggest drop-off here in terms of numbers is from that prevalent disease to diagnosis. And that's where we're losing the most number of women. And so I think our imperative is how do we improve that gap and then work on the others. And so I want to pivot to some evidence-based approaches. And what I think and what I alluded to before is in our usual care model, we can pour resources in, we can have task force, we can have physician leads, but it's not going to work unless we change our system. And a system that I think is a really innovative approach to achieve screening is collaborative care. And the concept there is infusing a care manager into routine perinatal care to achieve population-based care, patient-centered team care, treatment to target, kind of these concepts of shared care plans that the mental health team and the obstetricians are all aware of, so that OBs can play along and we can participate because we know what to expect and we know what general guidelines are. Population-based care where everyone's entered into a registry and we're tracking their symptoms. Even if they're not in my office as the MFM, I'm tracking her electronically to monitor her symptom progression, and then we meet in a multidisciplinary way to say, hey, let's alter something according to our algorithms, treatment to target. Our goal is remission. Again, just a population-focused way to make sure we're moving the needle forward. So this is a forest plot from one of the early meta-analyses. There's been a few that have been published since. And right, so the solid vertical line is equipoise, and on the left-hand side is usual care is better. On the right-hand side, collaborative care is better. And what you can see are, these are for depression remission outcomes. You can see compellingly data on the far right side of the graph. Collaborative care is a more efficacious system when implemented or in randomized trials, and now in 81 randomized trials, 81. Always makes me laugh, like who funded that 81st trial? And I was like, you know, if we just had one more data point over there, we would totally know what to do. But anyways, they're not funding my research. But what about perinatal collaborative care? And I think it's really different, and we need to be aware that these are in primary care, and no one's really studied this in quite as robust of a way in the perinatal context. And perinatal care is different. More care transitions. Obstetricians are very different, I think, than primary care doctors in many ways. There's competing demands. Postpartum care is woefully limited, and the prevalence rates can overwhelm a system when you're trying to build a health services intervention. The good news is two really brilliant people, Dr. Grote and Dr. Melville, have already examined this in randomized trials. Conveniently, they use the same colors in their graph. Makes me happy, where the blue is the usual care and the red is collaborative care. And you can see depressive symptom outcomes are improved with collaborative care compared to usual care. And I know I'm moving really quickly through this, but I think these data are really compelling that tells us these data that exist in the primary care realm probably translate to the perinatal context. But the question I have is all of these trials to date have identified, once women are identified, and they get randomized to treatment as usual versus collaborative care, how do they do? And we think they do better. But that's focusing on kind of the right-hand side of that care cascade. The big drop-off is in screening. And so my hypothesis is, gosh, if we could implement this system, it would probably give OBs and midwives and family medicine doctors a lot of comfort to know I have a system behind me, and so now I'm willing to screen because we've changed the way that we're interfacing and I have support. And so we implemented this at Northwestern, a model called COMPASS, a collaborative care model for perinatal depression support services. That's our weekly multidisciplinary meeting. We look really deep in thought, right? So like it's a good program. We implement all of the core principles. We're fairly dogmatic, rigid adherence to implementation strategies around collaborative care. We started almost 3 years ago now, serving 5 diverse OB offices. Our catchment area is around 3,500 women that deliver annually. And women are eligible during pregnancy or up to a year postpartum. And, we built this, and I hope people come because it was a lot. And as it turns out, when you build it, they come. OBs are just so desperate for a resource and for this kind of support. So we've had now close to 1,500 referrals to the program in just shy of 3 years, which is pretty incredible. And what I wanted to do is look at pre-COMPASS implementation and post-COMPASS implementation and compare rates of screening, because no one's done this before. No one's looked at the upstream effects of implementation of a collaborative care program, and then use some causal inference techniques to be able to say, gosh, did COMPASS do anything? And so these are kind of the crude analyses that, again, I'm kind of whirling through quickly, but what you can see are antenatal and postpartum depression screening completion. That was our goal. We wanted to screen at least once antenatally, once postpartum in accordance with ACOG guidelines. Pre-COMPASS is in the light purple, post-COMPASS in the dark purple, and you can see improvements in both. And I want to highlight antenatal depression. Initially, we had the task force, we did all the things, but we were around 40%, just like that Kaiser study. And we've gotten it up to 75, and now it's probably a little closer to 80% after implementation of COMPASS. It's not 100%, but it's moving a lot closer. Postpartum depression is a lot harder because we were pretty good at it before. So 92%, now we're at 96, 97% of women that are screened. And all of this is consistent even if we adjust using some advanced propensity score methodologies, right? Trying to control apples to apples epidemiologically. What is your likelihood of having that exposure to COMPASS? We see the exact same associations. And then I think this graph is pretty cool. So this is looking at the number of screens that are obtained per month, which is certainly a crude metric. But what I wanted to do is make sure that COMPASS wasn't just implemented at a moment of a secular trend where things were already just getting better and COMPASS just happened to plop itself in and take all the credit. And so in the blue line, you can see pre-COMPASS. In the orange line is post-COMPASS. And these are, again, number of screens that are completed. And what you can see is such a stark divergence, where screening rates really went up and they're continuing to go up after implementation of COMPASS, which is, again, just another metric in terms of epidemiologic causal inference methodologies to tell me that it's probably not an pre-existing secular trend. This is actually something to do with the program itself. So I guess my disclosure is I have a 3-year-old and a 1-year-old, and I think a lot about these boxes. And, my kids try painstakingly to put the little squares through the square holes, and I watch them and God, just put the peg in. And I think that's a lot like what we're doing when we're trying to get systematic universal screening to happen in OB offices, is we're just trying to force something that it's hard. It's a challenge system to exist. And then I watch my 1-year-old rip the top off and throw things in and then start to eat things. And I think that's what we need to do. We got to rip the top off, right? We have to change the system if we want to achieve universal screening. I think trying to force the same system to do something different is just not going to work. So with that, I will turn over to the pediatric aspect of things with Dr. Beers. Thanks so much.
All right. Oh, automatically happening? Oh, wow. Okay. I'm going to not touch. It's just going to happen. All right, perfect. Wonderful. I need one of these at home, just someone to magically take care of things. So good morning, almost afternoon, everyone. I'm delighted to sort of continue this conversation about screening. And I think, I think, again, I agree with Dr. Miller. I think we have a good consensus that screening is important. And the real question is, how do we make that happen and where do we make that happen? So I'm going to talk to you a little bit about why pediatrics. It's not just because as a pediatrician, I get to spend my days with those beautiful laughing babies in Dr. Welsh's videos, though that's a wonderful thing about pediatrics. But there's very good reasons to think about integrating perinatal mental health screening into the pediatric settings. no conflicts of interest. Pediatricians usually do not. And so again, we're going to talk a little bit about this and also think about, to Dr. Miller's point, about putting these square pegs in round holes, really thinking about a public health framework to how we approach screening. And I'm going to speak briefly about how we've applied that in our practices in Washington, D.C. as a bit of a case study. So again, we all know that screening is common. The things that I want to point out here, which I think are relevant to the pediatric setting, is that this is very much a family thing. And perinatal mood and anxiety disorders do persist well past the birth of the child. And so those are a couple important things to think about when we're thinking about pediatrics and pediatric practice as a setting for perinatal screening. There's also another really important piece about stigma, right? We've talked about this a lot in different ways in the conference, and I know in other places, but there is this expectation that having a baby is a very happy, easy event. And any of us who've had babies know that that is not the case. And so there are a lot of social stigmas and social barriers to seeking care. And so thinking about where are those places where families feel most comfortable, where are the places where they're going to develop really long-standing relationships, and those are places to think about as being a good place to identify perinatal mood and anxiety disorders. So pediatricians are great partners here. You know, this is a wonderful, some of you may know or be familiar with the work of Dr. Marian Earls, who really is a leader in this field in pediatrics. But I love what she says. Pediatricians have long recognized the two-generational nature of providing care for children. Addressing perinatal depression is an example of this, one that has a long-term impact on the health of the child, the mother-infant relationship, and the whole family. And we see kids, and we see parents, and we see families on a very regular basis through that first year of life, and more frequently than parents and mothers and families are seen in the obstetric setting. And I know from talking with my DC colleagues in OB that even under the best of circumstances, most of our patients are actually not getting back for that 4 to 6 week postpartum check. And so as pediatricians, we really have a very special responsibility to be thinking about the health of the parent and the health of the family. So just to sort of sum that up, and then I'm going to talk a little bit about what we've done here in DC, and then make sure we have a little bit of time for questions afterwards. You know, as we've talked about all morning, and as all of you have heard, when parents are healthy, when families are healthy, babies are healthy. When there is good attachment, when there's good early relational health, babies grow up strong and healthy, and they grow up to be strong, healthy, thriving adults. So as a pediatrician, it is my responsibility not just to make sure that babies have had their shots, but it's also to make sure that they are growing up in an environment that allows them to optimally thrive. I see babies a lot during the first year, as I pointed out, 8 or more visits in that first year of life. And that's for a first baby. If I'm taking care of a baby who is a second or third child, I've been following that family for a while. I may know them for 10, 12 years. And so that's a longitudinal and trusted relationship with a family where mom may be actually more willing to disclose to me that she's struggling with something, as long as I create an environment that is open to that. All that said, less than half of pediatricians do screen for perinatal mood and anxiety disorders. So it's not about the why, it's about the how, as you mentioned. So I'm going to talk a little bit about how we did the how in DC. I talked about this actually in more detail in our breakfast session, but really we've taken a public health approach to how we have addressed perinatal mood and anxiety disorder screening. And so we've really tried to address the issues around screening at sort of this nested public health approach, really thinking about what's happening at the individual and interpersonal level, what's happening at the organizational level, what's happening on the community level, and what are the policy and advocacy and regulatory supports in place that can support those things. And I'm not going to go into great detail about all of these, but I will sort of show you some examples of what we've done that have addressed these different aspects of the public health model. So the first thing we did is, from an individual and interpersonal level of actually doing the screening. So how do we do that? Anyone who's worked in a clinical setting knows that screening sounds easy on paper. It is not actually easy to implement in regular practice. And so actually several years ago in DC, we embarked on an effort to promote universal mental health screening for children at their well visits. And so this is where this is the context that we started within. And we ran and launched a citywide learning collaborative for pediatric practices in the city to help support them to implement universal, and this is for children, mind you, universal mental health screening in their practices. This is a very complicated map, but just to show you, we did a lot. We had quite a bit of good quality improvement support. We ran regular metrics for practices on how they were doing. We gave them reports. We had educational sessions. We had team meetings so folks could learn from each other. And ultimately, we were able to increase, and this is continued over the years, and we followed it through claims data, we've actually increased the rates of mental health screening overall, including perinatal depression screening, by over 900% in Washington, D.C. So this was successful and sustainable, and it was a good model for really providing that ongoing support to our pediatric practices to implement universal screening. So with that base, that actually started without, we didn't include perinatal mental health screening in that first round. But once we had developed that base and that infrastructure for conducting screening of this type in the pediatric practice, we then did move on to perinatal mental health screening. And so this is just a little bit of a take of our health centers within the hospital of after that initial test, we then moved to integrating perinatal mood and anxiety disorder screening in about 2016. Each clinic started at a different time, but bottom line here is you can see that sort of following that same pattern and following that same type of support, we were able to increase screening rates up to about 80 or 90%, depending on the practice. And of those, depending on the clinic and the time, anywhere from 12 to 20% screen positive. That's probably it's probably a bit of an underreport from what was really happening, and that's a whole other discussion. But we were identifying mothers who needed services. When we continued that out and continued to follow that, and actually we have 2019 data that's coming to completion that shows us still at around 80 to 85%. The bottom line here is that these results have persisted just once we pulled back some of that more intensive support. So once the systems were built, the screening continued. And again, slightly lower rates of positivity and whole other talk. We'll talk about that later. Or if someone has a question about it, we can take a question. And this is a little bit of a different way of looking at it, but also to just sort of show, looking at the scores sort of across the scatter plot across the 0 to 6 month well visits, that the screens are happening at all well visits, and we're getting positive screens at all well visits too. And so just sort of, a reinforcement of that recommended screening schedule and a reinforcement of the idea that that regular routine screening in pediatric practice is valuable and identifies mothers in need of support. So 2 quick things. I have great colleagues here in the audience, Dr. Jarvis and Dr. Soye, who are back there at the table. But just two quick points is that we think about this a lot in pediatric primary care because we have a longitudinal trusting relationship with families, but this is also screening that can happen in other places in the pediatric setting. So Dr. Jarvis conducted a study in the emergency department, and bottom line was that screening was feasible and accepted by the emergency department providers and identified mothers in need of services. About a quarter screen positive in the emergency department. And then when we get to the NICU, this is almost published data, as my conversation with Dr. Soye just a minute ago. It's a manuscript under review or under revision right now. But this was part of a study looking at family navigation in the NICU. And as part of that study, mothers completed this CESD, which is a depression scale, in the NICU. And actually what we saw is that almost half of the mothers screen positive on their depression scale. So the NICU, as we've talked, is a very important place for us to be thinking about this as well, and an important place where we can provide more intensive supports because of the type of relationship. And again, as Dr. Welsh was talking about, there's a lot of things we can do in that setting. So to sort of address from the primary care side of things, we've heard a lot, and it is important, and Dr. Miller mentioned this too, it's not, I actually don't think it's ethical for us to just screen and then say, well, go find, I'm really sorry that that you're having a hard time, you know, make sure you call your doctor and see if you can get connected with services. So it's important for us to think about what are the services and supports that we're offering to families when we do embark on a screening effort. And so as a part of that in DC, we've developed out a number of different initiatives. We have some online toolkits that are available to providers, publicly accessible. The link is actually at the end of the talk if anyone is interested in that. It helps walk through some of the logistic issues and some things around sort of pathways around screening and pathways of things to do under crisis management, action care plans. But we've also then developed out, you know, every mother needs support, and every mother needs social support, and every mother is going to have a low moment, and there's sort of a universal approach to that as well. So we've developed a Path to Wellness document that just helps walk mothers and families, fathers too, families through what are the things that they can do to sort of mobilize their social supports and mobilize the things in their life that are going to help create a more supportive environment. And that's available in English and Spanish. And then the DC MAP, Mental Health Access in Pediatrics program, is actually a teleconsultation program for pediatricians in Washington, D.C. that our team started. It's modeled after a national model, and we have integrated in supports for answering pediatricians' questions about perinatal mood and anxiety disorders when they come up in clinic. So if I'm seeing a patient and the mother screens positive and I'm not sure what to do or there's some complexity to the situation, I can call and talk real time to a child psychiatrist and or a psychologist and get their advice and support and potential referral to resources to help manage that family in my office right in real time. And then, of course, there's policy and advocacy. We talk about payment, and payment is important because we have to be able to pay our staff to do the things we need to do to provide service and care to our patients. And so the most important thing I want to point out here is that CMS has clarified that screening for perinatal mood and anxiety disorders is allowed in the pediatric setting and is considered as a service to the child because it is a proxy for infant mental health. States may also cover treatment for the mother, even if the mother is not Medicaid enrolled, if the child is Medicaid enrolled. So this is just an example of some of the policy things that are important and some of the policy supports that we can continue to push for. So this is sort of my last piece, and I'll go through this quickly because a lot of it is really going to probably come up in the questions, but really the facilitators are champions and supportive teams and clear pathways and clear supports. And the barriers are the things that we all know. Their time and lack of all of those other things, lack of support and lack of on-site resources. And I think also the other real barrier is siloed systems. When we operate in our own settings and don't do a good job of talking to each other, we don't do as well in providing care for patients and families. And so here are some resources. The AP has a wonderful screening resource, and then I've also given some of our local resources. And the perinatal mood and anxiety disorder resources are, there are some things in there that are specific to DC, but much of it is very generalizable to your own settings. And actually, a special thank you also to Penny Theodoro, who is part of our team, also sitting in the back row, who is really instrumental in developing out a lot of these things. So, all right. I did it.
Emily and Lee, thank you for a wonderful presentation. I'm sure there are lots of questions, so we can open up the floor.
Thank you so much for all of that. So I am going to talk specifically about the obstetric screening. Like you said, we need to rip the box off the top. I think for too long, obstetricians are just focused on delivering the healthy baby. And my apologies to any OBs in the room. I'm sorry. But I think we have to help OBs to realize that they are the de facto primary care provider during the childbearing years, and dial it all the way back to medical school and OB residents. I did a quick Google search just during the conversation here, and there are only 180 medical schools and 243 OB/GYN residency programs. So it's a number that we can tackle. And to dial it all the way back, that the OB should be saying from the moment a woman is pregnant, even before that, your mental health is as important as your physical health. We're going to check in with you every time we see you. And to change the paradigm in how obstetric care is provided. I remember when I was having kids, you would go to the obstetrician, and each time they wanted you to see a different obstetric provider in the practice because they wanted to make sure you knew all of them for whoever was going to deliver the baby. Well, it doesn't really matter. The delivery is now by hospitalists, right? What I think moms want is a relationship with their provider like the longitudinal trusting relationship they have with their pediatrician. So I really think that we need to change the obstetric provider practice on its head and make them beat them over the head and make them understand how important it is that they have to discuss this with moms and they have to screen. And there is no excuse not to. We have resources. We have Postpartum Support International. We have resources all over the country. So I'm going to speak more later during the panel discussion. You can tell this is a little bit of a passion of mine. But I don't think there is any excuse any longer for obstetricians to not screen.
I think most of us in the room, and I certainly align with those same goals. I think I think the question at hand is whether to continue to beat obstetricians over the heads with a recommendation or evolve the health system to support them in achieving those goals. And so I think with that framework, I wholeheartedly agree, is that, like, I think we have to, it is challenging in 15 minutes to, manage someone's, anticipatory guidance about pregnancy, manage her blood pressure, take care of her pre-existing diabetes, all the social determinants of health, and then get into, right? So it just becomes a little bit complicated, and that's why I think it's a health systems approach. It's not what an obstetrician has to do in this same framework. The framework has to change if we're going to meet this goal.
Just add, I'll throw the pediatricians under the bus. It's not like the pediatricians have jumped, less than half of pediatricians are screening. And so I think echoing that comment that it really is a health systems approach. And I think that the one difference is that I think we've been working on it perhaps a bit longer in pediatrics than in OB. And so there's been a little bit more time for culture shift. So there's maybe at a different stage of development, but there's still a long way to go. And there's still a lot of support to be put in place to really allow universal screening to be able to be implemented across pediatric settings, not just the OBs. You're welcome.
So I'm proud to be an obstetrician, and you don't have to hit me on the head. And I would like to say, I'm not practicing anymore, but when we practiced, maternal stress was very important to us. Mm-hmm. We were taking care of diabetic mothers, type 1 and 2, and they are more stressful than regular stress. So I just want to point out that we do, the obstetrician, care about maternal well-being. The second comment that I want to say is that I'm from the Pregnancy and Perinatology branch in NICHD, and we are very interested in maternal well-being, and I want to see a lot of grants coming from this audience to address these issues. Thank you.
I see a lot of people taking notes. So.
Hi, excuse me if I'm not as eloquently spoken. I am not a doctor of any kind. I am more of a policy, public healthy person. And so my question is, do you think that requiring screening will help address some of the disparities that are leading to Black mothers dying during childbirth and with postpartum complications, because a lot of that issue wraps up in them not being heard and their concerns not being taken seriously and being dismissed by their providers. So I'm just wondering if you think that this kind of screening requirement or expectation would help to combat some of the disparities that Black mothers are facing.
Yeah, I think I'm glad you bring that up, and I think it is incredibly important and something that's a huge focus and appropriately so on the forefront of clinician interventions, policy changes. So super, super important. I'd be hard-pressed to believe that just giving a piece of paper and looking at an EPDS or a PHQ-9 is the thing. That'd be super cool if it was. But I think then it's the rest of the care cascade and what we do and what kind of wraparound services we can provide. So I think it is a step forward. I don't think it's the only step that we need in this huge, embarrassing disparity that exists.
Yeah, I would agree with that because I think, I think the answer is yes and, right? Because I think that there can be value in mandating screening. It's actually in part what triggered our Mental Health Screening Learning Collaborative in DC was that it was put into our Medicaid managed care contracts, and we were able to use that as a leverage to say, okay, if this is a requirement, let us help our practices do it well and do it in a way where we can connect to good, accessible, culturally competent services. My fear is that often when screening is mandated, it becomes a checkbox, and that in and of itself doesn't do anything additional in helping women be heard. And so I think your point is exactly right. And I think it's a yes, but we also have to make sure we're really addressing the access issues, and we're really providing care and services in a way that is accessible for every single one of our patients, and in a way that acknowledges the significant inequities in care and structural racism that exists in our health system.
I'm a pediatrician in DC, and I have a question and a couple of comments. Screening does take time, and one way that we've helped cut down time in our office is to have the parents do it online before they come in, so we have a chance to review it before we see them. I'm wondering, though, for the postpartum, how that would really work out in terms of, is mom just tired and irritable when she did it, or just got home from the hospital and so she's going to come in the next day? And I don't know if anybody has ever looked at the timing in that frame in terms of validity.
My opinion on this, I think administering a screen is one piece, but I think the psychoeducation that precedes the screen is actually another important component. And I'm always struck on a postpartum visit how many women will have, we use the PHQ-9, but a PHQ-9 score of 0, and that's like physiologically just completely impossible. And so that strikes me as we're giving a screen that has imperfect test characteristics in the absence of the antecedent psychoeducation that is needed. And so I don't think it's enough to have an MA plop a screen down without kind of the anticipatory discussion of why this is important and why it's important to fill out honestly, and then having that conversation.
And I also think, certainly our experience, and I think this is borne out in the literature as well, is that it's actually a parent's distress is more likely to probably be underreported on the screen than overreported. I think it's also useful to, and I agree, I actually think that, we have not been able to do it that way, but sort of sending an electronic screen ahead, there can be some real value in that. It does allow, in many ways, the parents to actually complete it in a less stressful circumstance, right? Because you're not sitting in a waiting room with a bunch of toddlers running around and wondering when you're going to get called back and all of that other stuff, and juggling car seats and stuff. So there are some pieces there too, but also remembering that a screen is just that, it's a screen. And I think of it as a gateway to conversation. It's a gateway to saying, this is something that I think is important and I know impacts you and I care about. And so there have been times when I have families who fill out the EPDS and it's 0 every single time, and then they've called me back or emailed me or gotten in touch with me at 9 or 12 months of baby's life and saying, you know what, I am really struggling, and I remember you asked those questions before, and I think you might, do you have any resources that might help me? So it's more of a gateway to the conversation is the way I think of it.
So again, this is Catherine, just being mindful of my duties.
Thank you.
This is what we anticipated. There'll be an opportunity for us to continue the conversation during the panel, and individual folks can go up and speak with Lee and Emily. I have been seeing 2 persistent hands, so we'll just take 2 questions. I'm going to ask they be brief.
Yeah, we'll answer quickly.
Okay, thank you. Yeah, just to say, in the UK, we do now have universal screening. The midwives screen a booking clinic for depression. And absolutely what you say is terribly important, and that is that there's underreporting, and we can see that probably only about 2/3 of those who should be reporting mental health problems are reporting, and willingness to sort of take action, whether action is taken as a result of that screening, is woefully poor still. I think one of the dangers is normalization, where normalization of the experience of distress in pregnancy. Of course you're distressed, you're tired, you're nauseated, and that's a real challenge. So I think it's made us think very carefully about when we do the screening. So do we do it during a busy booking clinic when we're screening for all sorts of other things, despite midwives' enthusiasm for doing so? Actually, is that the right time? And often women will report later about problems they experienced at the time and say, I just wanted to get out of that clinic. I didn't want to talk about it at that moment. We were looking at the use of it at the ultrasound scanning clinic, where there seems to be a little more opportunity. And certainly for a trial we're doing of psychological interventions in pregnancy, it's a much better time to recruit people into it. So, I mean, it's just a comment and that is definitely the next stage. Screening is only one small part of the pathway.
I think also remembering it's a series of screens, too, that helps address some of those issues. It's not just a one-time.
Not to pile on in terms of places that we need to look to in terms of screening, but I find that a subset of this population that is often not screened and not seen and not heard are women who have had perinatal losses or neonatal losses. And I would like to just at least point out, and perhaps it's applicable to the data too, is that these are women not directly after the loss, but certainly 3, 4, 5 months out should be screened, because that's about the point in time when grief could shift to depression. So just would love to hear comments on that. And I know I'm standing between everyone and lunch.
Yeah, I mean, I'll address it really briefly, and I think our collaborative care is a really nice system in that it's a population approach with symptom trajectory tracking longitudinally, which I think speaks to that. And I can't tell you the number of women that, months and months after, we see their screens, they're really high, and those that get better because grief response, and those that don't, and being able to reflect back that data. So I think the heart of the issue is longitudinal monitoring and keeping someone engaged in a system of care, whatever it might be, which are, again, our normal health system unequivocally does not meet the needs of that specific population. So thank you for the question.
Just kind of want to bring this back to the fetal brain. This was all very important, but I always like to think of that we've achieved what we set out to achieve and what's that going to look like, and then try to figure out how to get there. So if we assume that you guys get the infrastructure in place and screening becomes possible and it's a slick, a well-functioning system, there are several other issues that other people have to be getting lined up. So getting back to what Elizabeth was saying and the work that Catherine Monk does, not stress and anxiety and depression, it's a whole constellation. And people like them are going to have to figure out, and my team, what precisely is affecting the fetal brain. And more critically, and this gets back to an issue that you guys are dealing with, and that is not just getting a screen done, but knowing when, because of the critical periods of fetal brain development. So I'm hoping that we can get to a point where we say depression has its main effect during these months, and so that we can really tailor the timing and the types of questions that we ask with the fetal brain in mind.
Here. I would say, the most common and very fair and accurate question that we get asked in this work is, if we're going to screen, why and what difference does it make, right? And so that's where, I actually think this collaboration and continuum of care around, the way we all work together is so important, and it's so important to decrease that siloing between pediatrics and OB, and between the basic science and between the translational research and the practice. And the more we bring this all together, the way you all the way it is together in this room, the better we are going to be able to provide good services and have better outcomes for children and families. So here.
Great place to stop. So, well done. Thank you.